Hi,
Hi.
would you like to meet little baby?
Yes, I would.
Diga, hola.
Hey, buddy.
Hi.
Hey, you. Oh, you come to learn about pharmacology, little one? Huh? Yeah, we're starting them early.
Yeah.
Okay, now don't be giving your mom the answers, okay? You play it straight, okay, buddy? You play it straight. You keep your mom in line, all right?
Yes, yeah.
Stephanie, remind me, what's his name?
Seth.
Seth. Okay, Seth.
Okay, bye-bye.
Hi, Seth. Hi, buddy. Oh, we got people at houses that are out of power. So some folks won't be able to join us, I'm afraid. Wish they would not have closed the library. I think that would have been a good thing to have. Oh, well. Can't have everything. All right, folks, do the slides move?
Yes.
They do. Okay, good. Then we're all right. Well, according to my watch, it's time to start. This is not the most optimal way to run a class, but it's what we have, so it's what we'll do. The quiz is online. It is a 5-question quiz. It's drawn largely from the questions you guys so graciously supplied. Shouldn't take you long to take it, and you have until tomorrow at the end of the day to take it. And those who are not able to be here, this will be recorded. The link will go on the YouTube page, my YouTube page, and please help people out if they can't come. Devin, it is great to see you. You responded no to the YouTube, to the Zoom invitation, yet you're here. Good girl, you're here.
I did not even see that or know how I said no. So
I got the email that said, Devin Thomas said no, to which I said, well, fine, be that way.
that's my bad.
All right, well, whatever. All right, let's have a word of prayer, then let's get started. Father, thank you for this cold, icy evening. And we pray that you would help the trees to hold up, not crash on any lines. And we pray none of us will lose power tonight. Thank you for watching over us for this class. And even though these are less than optimal conditions, I pray that you'd help us all to learn, use our time wisely. In Jesus' name, amen. All right, gang, if it gets to 7:45 and I haven't given you a break yet, someone set up a flare, because you know me, I start talking and I lose track of time. All right, so general anesthetics in general are suppressors of the central nervous system. They are either things that potentiate GABA neurotransmission. They will do that either directly or they will do that indirectly. They may directly interact with the GABA receptor. They may have other ways of potentiating GABA neurotransmission. The other thing that they do is they will inhibit the receptors of stimulatory neurotransmitters, the big one being glutamate. And so the major glutamate neurotransmitter is the NMDA receptor, and several general anesthetics are antagonists of the NMDA receptor. So those are kind of the two main mechanisms of general anesthetics. General anesthetics in general are fairly lipophilic, so they cross the blood-brain barrier quite readily. That can complicate their administration sometimes. They have to be suspended in these very lipid-rich solutions and things like that, and that makes them a little harder to give. The propofol, for example, kind of looks like milk when you give it, but that's what you have to give when you give propofol. So the stages of general anesthesia, you have an analgesia stage, that's stage 1. And as you see here, it's characterized by loss of pain sensation. The patient at this point is still conscious and able to communicate, but they are starting to lose pain sensation. Then there is an excitement stage. This is a period of excitement that might include combative behavior. What you're seeing at this point are signs of sympathetic stimulation. And so it's kind of common to have patients who are being administered agents, they'll all of a sudden start to talk a lot. And that's usually the excitement stage. This stage is pretty short-lived in some cases. Then next stage is the stage where you want to live for surgery. This stage involves relaxation of muscles, regular respirations, progressive loss of eye reflexes, progressive loss of pupil dilation. So eye reflexes in general, both motor and sympathetic and parasympathetic. This is a stage in which surgery can be very safely performed. If you go too deep into anesthesia, then you have the stage of medullary paralysis. This is a very deep central nervous system depression with loss of respiratory and vasomotor central stimuli. And the lights keep flashing here. Great.
Hearing gainy too.
Oh, okay.
Yeah, we might lose power.
Yeah, well, just keep going as best we can. So you'll have loss of respiratory and vasomotor central stimuli. Death, unfortunately, can occur rapidly in this stage. It's considered a critical period in which anesthesia has become too intense. So when you are administering anesthesia, you want to make sure that you are between 3 and 4. You don't want to go into 4. You want to stay in 3. These are summaries of what I just told you, so I'm not going to belabor these because I've already talked about them. I'll let you read those over at your own leisure. So the various examples of general anesthetics, some of these are adjuncts to general anesthetics. So the one to point out first is fentanyl. Fentanyl decreases sympathetic drive, and it decreases the quantity of other anesthetics that are used. That's one reason why fentanyl is used a good deal during the use of anesthesias, because the amount of anesthesia you need to use is a lot lower if you use fentanyl. Benzodiazepines are typically used either for induction or they're used if the patient is anxious. In particular, the drug of choice here is midazolam. Midazolam is a very short-acting benzodiazepine. It's easily the shortest. It has the shortest half-life, and it acts pretty quickly. And it's a very good anxiolytic. So it's an anxiolytic and an amnesiac. The downside of midazolam is that it's got a hangover when you wake up. You wake up a little bit drunk, so to speak. Your speech might be a little bit slurred. You won't walk terribly straight. And that will last even after the drug has worn off to some extent. These others might be used, these are longer lasting drugs. They're used under special circumstances. So diazepam is a good muscle relaxant. If they need a muscle relaxant because they're in a good deal of pain, muscle pain before surgery. You can give Valium and that will do things similar to what fentanyl does, in that it decreases the amount of anesthetic you have to give. Midazolam is usually used as an anxiolytic. So these down here, these are intravenous drugs. The one that's definitely used the most is propofol. Propofol is good both for induction and maintenance. So I keep using those terms. Why don't I define them? So to define them, we will go to our makeshift blackboard, which is right here. So induction is from the beginning of anesthesia to stage 3 of anesthesia. So it's the beginning. So induction, essentially, if this is stage, and you want to get someone to hear, induction is right here. Then to keep them in stage 3, that is called maintenance. Now, it is not uncommon to use one agent for induction, use another for maintenance, or you can use one compound for both of these. That is one of the beauties of propofol, is that propofol is good for both induction and maintenance. Good for induction, also good for maintenance. After the procedure, you want someone to wake up. You want to get them from here back up to here. That's called recovery. In order to facilitate recovery, you want to make sure your agent wears off quickly. That again is one of the great advantages of propofol is a very short half-life, wears off very quickly. And the sort of really dopey, draggy sort of feeling you have doesn't last very long. It lasts on the order of minutes rather than like an hour or two like midazolam. So propofol, because of that, is very heavily used. It's also used in the ICU. Propofol is especially useful if someone has increased intracranial pressure, because propofol is a vasodilator. Since it's a vasodilator, it can increase the cerebral perfusion pressure, which you want to keep this up so that the brain has enough pressure. The reason this is useful is that propofol will decrease brain metabolism. So it's quite useful in the case of people with some sort of traumatic brain injury. So those are the 3 stages: induction, maintenance, recovery. And some of the agents that we will talk about are good for induction, not so good for maintenance. Others are good for induction and maintenance. Others are great for maintenance, not so good for induction, so on and so forth. That's what we'll talk about with these agents.
What does ICP mean?
Increased intracerebral pressure. So someone has a brain injury, they might have a bleed or something like that. Their intracranial pressure goes up. So you have an increase in intracranial pressure. That's usually due to head trauma of some sort. It could be due to hemorrhagic stroke, but more often than not, it's due to some sort of traumatic head blow or something like that, car accident, sports injury, something like that. That's ICP. And because some types of bleeds in the brain can be slow, this may be insidious, whereas in others, it can be a very fast bleed. So it depends on the type of injury. All right, back to here. So propofol is probably in many ways your go-to because it's good for both induction and maintenance. Very, 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 very useful agent. It's especially good for short procedures because of that very quick recovery period. Much smaller hangover effect for a quick recovery. Problems with propofol include in some people, when it goes in, it either burns or you might feel cold. Usually you get decreased blood pressure. So if you have someone with low blood pressure, this is going to lower it even more. Consequently, you may have some bradycardia, hypotension. That may lead in some cases to pulmonary edema, but in most people, that's not going to be much of a problem. So the lowered blood pressure is a potential issue. Etomidate is an agent that is particularly useful if you want to use an agent that does not lower blood pressure. So etomidate does not lower blood pressure the way propofol does. That makes etomidate rather useful. Also, remember, because propofol will cause vasodilation, what if someone is prone to migraines? If someone's prone to migraines, propofol, they might cause them to wake up with a really rattling headache. In this case, etomidate might be a better agent because etomidate causes less cardiovascular depression. So etomidate is preferred for people with coronary artery disease or people with cardiomyopathy or people with cerebral vascular disease. Or if someone has lost a lot of blood volume, they have hypovolemia, etomidate might be your choice as well. Now, big downside with etomidate is that it causes adrenal suppression. And if someone is on etomidate for a period of time for recovery, you might have to give them hydrocortisone in order to make sure that they have enough adrenal function to be able to maintain their blood glucose levels. So the big adverse effect with etomidate is adrenal suppression. Ketamine increases cerebral blood flow. Therefore, it increases intracranial pressure. Therefore, if someone has head trauma, ketamine is not recommended. Having said that, where ketamine gets used the most is in the ER, because ketamine is, number one, very good for induction, very good for maintenance. Ketamine, unlike propofol, has analgesic properties, so it has anti-pain properties, and it also has muscle relaxant properties. That makes ketamine really useful in the emergency room. Ketamine stimulates the sympathetic nervous system, so you get increased cardiac output, but you get dilation of the bronchial tubes. So it's perfect for people with hypotension and also for people with bad asthma. Downside of ketamine, it causes, it's a dissociative anesthetic. So the patient is not completely unconscious. They can breathe on their own. They can open their eyes, they can swallow, they can move involuntarily. They don't remember the procedure, they don't feel pain. But when the patient wakes up, they can have hallucinations and delusions. Because of that, when someone wakes up from ketamine, they're going to need to be watched. And sometimes these delusions are pretty benign. For example, they might say, oh, to you, oh, you came in and you told me that my family was here. You might say, I did? Yeah, you came in and you told me my family's here and my mom was so proud of me for getting this procedure. And you're thinking to yourself, that never happened. And it's a ketamine hallucination, but it's completely benign. Other people might see something a right bit stranger. So if they tell you things about pink dragons or something like that, just kind of nod and smile and say, yeah, cool. Yeah, you should, yeah, fantastic. Opioids are going to be used, especially if the patient has to be intubated. Intubation is very painful. Opioids are necessary for that. Again, opioids like fentanyl can decrease the amount of anesthesia you need to give. Benzodiazepines are usually given as anti-anxiolytics. These can rapidly induce unconsciousness, especially in combination with the anesthetic. For maintenance, sometimes, and this is especially the case in children who don't like needles, gaseous anesthetics are used for induction. Gaseous anesthetics are usually not used for maintenance. The big exception would be nitrous oxide for dental procedures. So the dental procedures usually, they will take less than 15 minutes on the average. Usually too, with something like nitrous oxide, you'll have some sort of relaxant that the patient is given in order to keep them relaxed. But typically these are used for induction. They have their uses, but they also have their issues. So these anesthetics, they go from the alveoli of the lungs throughout the parts of the body. These anesthetic agents are lipid soluble. They accumulate in the body fat over time. That increases their potency. Inhaled anesthetics with high blood solubility will bind to blood proteins and they'll have a slower onset and recovery. So here are the opioids, some of the opioids. The fentanyl is probably the big one. These others are kind of derivatives of fentanyl. Remifentanil, alfentanil, sufentanil, so on and so forth. They work about the same as fentanyl. If you use propofol, you need to give something that will kill the pain because propofol has no analgesic activity on its own. And fentanyl is usually the drug of choice. I talked about benzos already. I talked about these already. All right, the gaseous ones. Oh, and all these are given intravenously. All right, so the gaseous ones, their mode of activity differs, but by and large, they suppress the central nervous system. Primarily used for induction. So nitrous oxide is used in the United Kingdom. It's used during pregnancy because it takes the edge off labor and delivery. I don't think it's used like that in the United States, although I talked to a couple of midwives who said they used nitrous oxide. Of the volatile liquids that are used, You have desflurane, enflurane, isoflurane, and sevoflurane. Sevoflurane is definitely the one that gets used the most out of these. Let's talk a bit about nitrous oxide first. So nitrous oxide has an analgesic effect. That makes it quite useful, especially in dentistry. It also has a so-called second gas effect. Second gas effect. That means if you combine it with other anesthetics, it lowers the therapeutic dose required for the other agents. Now, something to be aware of with nitrous oxide. The respiratory system responds to hypoxia by increasing the respiratory rate. Nitrous oxide diminishes that response. So you might not notice hypoxia very well. So you have to monitor arterial oxygen saturation at all times when someone is receiving nitrous oxide. Nitrous oxide can also cause expansion of trapped gases in closed body cavities. Consequently, it is contraindicated for people with bowel obstructions and people with a pneumothorax. Nitrous oxide tends to act as an NMDA receptor antagonist. Has very low solubility in blood and lipids, so recovery from this gas is very fast. Now, these other volatile liquids, these are all halogenated inhalational anesthetics. They all end with ane. Well, rain, R-A-N-E, rain. So this includes halothane, which is not listed here, enflurane, which is listed here, methoxyflurane, which is not listed here, desflurane, and then sevoflurane. These agents act as dual activity NMDA receptor antagonists and as GABA receptor agonists. So these give you a twofold activity. So haloflurane, H-A-L-O, halothane, H-A-L-O-T-H-A-N-E. This dilates airways, so it's good for asthmatics, but in Western countries, it's no longer used because in rare cases, it will cause severe and sometimes fatal hepatotoxicity. So halothane is not used anymore. Methoxyflurane is also not widely used because of its nephrotoxicity. So that leaves these others. Desflurane is very useful. The problem with desflurane, it has a quick onset and very quick recovery time, but it's pungent. So it irritates the airways and it can cause coughing. So because of that, desflurane doesn't get used a whole lot. Enflurane, also very useful. The problem with enflurane is that it lowers the seizure threshold. So it's contraindicated in people with epilepsy. Whoops. So of these, sevoflurane is really the one with the least downsides. It has a rapid onset, has low pungency, and it does very little to cerebral autoregulation.
Dr. Baratovich,
Yeah,
did you say enflurane lowers the seizure rate or raises
yeah,
it?
it lowers the seizure threshold.
Okay, thank you.
So it's contraindicated in folks with epilepsy. That's the problem with enflurane. Other than that, it works pretty well. Works quickly, you recover quickly, but that seizure threshold thing is the problem.
Okay, thank you.
Now, caveat with the inhaled halogenated inhaled anesthetics. All of them can cause malignant hyperthermia. Malignant hyperthermia is a condition whereby you get increased release of calcium stored in muscle cells that causes them to contract without resting and generate heat. So you get muscle rigidity, hyperthermia, metabolic acidosis, tachycardia, and ultimately the muscles can break down in a condition called rhabdomyolysis. So malignant hyperthermia, all the halogenated, can cause this. So the symptoms, as we said before, you get muscle rigidity, you get rhabdomyolysis, that's a breakdown of the muscles so that you start to get muscle proteins sloughed into the bloodstream, and that can cause kidney failure. You get hyperthermia. Because the contracting muscles release a lot of lactic acid, you get metabolic acidosis and tachycardia. The treatment for this is a drug called dantrolene. So, nurse anesthetists and anesthesiologists will have a so-called hyperthermia cart. And that hyperthermia cart has a dantrolene on it. So, first of all, your job as the nurse is to make sure this is ready, and then to know where it is. So if you see signs of this, you reach for it, and you are John or Jane on the spot to give the patient the dantrolene, because this malignant hyperthermia, it can be fatal. Now, nitric oxide does not cause this. So nitric oxide, no malignant hyperthermia. If you remember that, essentially remember nitric oxide, it's just the halogenated ones that cause this. Allergies to anesthetics occur. They're not terribly common, but they do occur. And that's why medical histories are so important. You simply tell people, ask people, have you ever reacted to any anesthesia before? Does anyone in your family ever reacted to it? And if the answer is yes, you can skin test people to see if they're sensitive to it. There are procedures for that. One of the very common reactions to anesthesia postoperatively is shivering. And that is a form of myoclonus. That myoclonus tends to wear off pretty quickly. It's not because the patient is cold. That occurs with propofol. It occurs with virtually all general anesthetics. Excitability may occur, and particularly in kids. After general anesthetics, people are unsteady on their feet and they may want to run into the bathroom and get dressed or something like that. And you need to emphasize to them, take it slowly. This is not a race. Please walk slowly. You know, you're not supposed to run in the hospital, you know, something like that, and try to get people to slow down. Some medications can cause mast cells to degranulate and can cause bronchoconstriction. There's one anesthetic in particular called thiopental that's used. It's not on any of these slides, but thiopental can cause mast cell degranulation. So it can cause bronchoconstriction. Thiopental is a barbiturate. So it will cause cardiovascular depression. But if someone gets bronchoconstriction with thiopental, you can give them essentially Benadryl, diphenhydramine, and that will be a complementary treatment essentially to prevent the thiopental from causing this mast cell degranulation. Other things are given before, after, during surgery. It will depend on the patient, depends what the doctor wants the patient to have during the surgery. If their heart rate needs to stay low, they can be given beta blockers or something like that. Yeah, it depends. And these are just, droperidol. Droperidol is a drug that is given to prevent post-anesthetic, post-operative nausea. Droperidol is a drug that can do that. It's quite good at that. And it has also anesthetic properties. So droperidol can be given as an adjunct, and droperidol will usually not only help as an anesthetic, but it can also help with nausea. Droperidol has its share of caveats. Droperidol can cause QT interval prolongation. So it can also cause chills, hypotension. There's another drug called ondansetron, goes by the trade name Zofran. That's probably the anti-emetic that's used the most in hospitals. That can be used instead of droperidol. Ondansetron does not have any anesthetic properties to it, though. That's why someone might prefer to use droperidol. We'll talk about the paralytics. That's what these are here. And then bethanechol is given if your bowel has trouble opening up after internal surgery. You have ileus, you have constipation, something like that. Bethanechol essentially opens up everything. And it works, and boy, howdy, does it work. Promethazine or Phenergan is a very good anti-nausea drug that can be given postoperatively. And I'm going to skip this because I will talk about those drugs at another time. All right. Are there any questions about the general or local anesthetics that anyone has? Please don't use the chat function. Go ahead and use, just unmute yourself and ask, because if you use the chat function, I won't be able to see. No questions? Okay. All right, so then let's talk about opioids. You know what? Let's take our break now. Let's take our break now. It's a little early. We'll take 5 minutes, come back, do opioids. And if we finish opioids, we'll just start with non-opioid painkillers. So go ahead, take 5. And so we'll be back at 7:43 or thereabouts.
Dr. Bradovich,
Yeah,
did you see that people who lived in England during mad cow disease can now donate to the Red Cross?
I did not see that, no.
It's been all over my face. Well, their ads have.
All right, so I can go donate possibly, if they'll have me. All right, so it looks like. All right, let's get back in the car and start driving again. If you're going to be a nurse anesthetist, you have to like math, because there's a lot of math in being a nurse anesthetist. All right, so opioids are analgesics. They are pain relievers. They're the big gun when it comes to relieving pain. They're being used less and less for acute pain. They're being used more for chronic cancer pain. The evidence for the efficacy of opioids in treating chronic non-cancer pain is actually controversial. Their long-term effectiveness, some studies say yes, some studies say no. So some doctors will simply not use them. For acute pain, extended release, long-acting formulations tend to be associated with overdose and unintended drug use, unintended long-term drug use. Because of that, many physicians now will not prescribe opioids unless you've tried everything else. Things like rest, heat and ice, elevation, immobilization, physical therapy, that sort of thing. Acetaminophen is probably one of the biggest painkillers that's used, but acetaminophen as a painkiller is good for mild pain. It's not really very good for much else. Combining acetaminophen with caffeine might, I emphasize might, provide additional pain relief. But opioids really are the main painkiller that people think about when they think about severe pain. So there are opioid receptors that are found on various neurons. There are mu and kappa and delta and other types of receptors. Definitely the big one is the mu receptor. So the mu receptor causes definitely the most analgesia of the opioids, of the opioid receptors. Also causes respiratory suppression, euphoria, sedation. The kappa receptor, when activated, also relieves pain, but also causes suggestion, and it decreases GI motility. And the mu receptor, when activated, does seem to be associated with physical dependence. So how do these drugs work? These receptors are found at the axon termini of presynaptic C fibers and in the dendrites and cell bodies of postsynaptic neurons that transmit pain signals. When these particular receptors are bound, you can see they prevent the influx of calcium through voltage-gated calcium channels. Therefore, the amount of the stimulatory neurotransmitter that gets released is lower. Secondly, they also bind to this receptor found in the dendrites and cell body of the postsynaptic pain transmission neuron. And they tend to prevent the efflux of potassium and they also decrease the influx of calcium. Therefore, this neuron becomes hyperpolarized. So you don't get as much activation of the NMDA receptor. You then have these other events that tends to hyperpolarize it, that inactivates the neuron, that decreases pain receptor transmission. It also prevents release of the EPSP inducing neurotransmitter, that being glutamate, by preventing the influx of calcium via the calcium voltage-gated calcium channels. I'm not so interested in you knowing the signal transduction bits here, just that the signals essentially from these C fibers, and remember, C fibers, when it comes to your visceral organs, they are the main transmitters of pain signals. The release of glutamate and the reception of glutamate are both dampened when these receptors are activated. So the opioids will consist of complete agonists of the opioid receptors, partial agonists, and then some will be agonists of one group of opioid receptors, but not agonists of others, or agonists of one and actually antagonists of others. Most of the ones we'll talk about will be full agonists, so just keep that in mind. So when are opioids indicated? So they're indicated, of course, most famously for relief of moderate to severe pain, cancer pain, postoperative pain, pain associated with myocardial infarction, postpartum pain, so on and so forth. They're also used for sedation. We saw that with fentanyl. It's used in combination with general anesthetics. Also, it's used to reduce bowel motility. So certain types of opioids, because opioids will tend to reduce GI motility, if you have severe diarrhea or something like that, opioids can tend to reduce that diarrhea very effectively. And also, and how opioids do this is not completely clear, but a couple of opioids are pretty good cough suppressants. So the full agonists include drugs like morphine, of course. Morphine, by the way, is the opioid against which all the other opioids are measured. So when the potency of an opioid is expressed, it's always expressed relative to how much morphine it would take to equal the efficacy of this particular opioid. So opioid potency is recorded in something called MME. MME. And MME very simply means morphine milligram equivalents. Morphine milligram equivalents. So 1 milligram of morphine is equal to half of, say, methadone or something like that. That's not, I just made that number up out of thin air. But, well, here, let me read you one. So tramadol, for example, the morphine milligram equivalent of tramadol is 0.1. So that means tramadol, a tenth of a milligram of tramadol is as potent as 1 milligram of morphine. So tramadol is 10 times more potent than morphine. That's usually how you report these things. MME, morphine milligram equivalents. So these come in various forms. Morphine is usually given parenterally, so it's given subcutaneously, intramuscularly, epidural, intrathecal, intravenous. There are oral forms of morphine that are used. Fentanyl is usually given parenterally, but there is a transdermal patch, and There are strips that you can put between your cheek and gum, so to speak. Meperidine, that's a drug you might know by another name, Demerol. Meperidine in England is called pethidine. Pethidine. So if you see papers talking about pethidine, because the British drug companies tend to sell their stuff in Europe, if it's a European paper, they will call meperidine pethidine typically. Methadone comes in an oral form, but it's usually given parenterally. Codeine comes in parenteral forms, but codeine is almost always given orally. Oxycodone is usually given orally, although there is a suppository form of oxycodone. And then hydrocodone comes in several different forms as well. So fentanyl is the most potent full agonist. It's used as an anesthetic medication due to its rapid onset and its short duration of action. Fentanyl, of course, is the drug of abuse for people now with opiate use disorder because it can be made so cheaply. Meperidine is used to relax uterine muscles and inhibit contractions during labor. Unfortunately, it can produce respiratory depression in the baby. So that's a downside of it. Codeine is a weaker full agonist. It can be taken orally, and it's often mixed with other analgesics like acetaminophen to treat moderate pain. Codeine and hydrocodone is not listed on here, are also useful as antitussives. Antitussives. That's anti-TUSSIVE, meaning that they relieve coughs. Methadone is an opioid that does not cause euphoria. It has a long half-life. So because it has a long half-life, blocks the euphoric feeling, it will decrease withdrawal symptoms for people with opiate use disorder or heroin addiction. You can then wean someone off methadone gradually. And that's essentially the strategy behind methadone clinics. Methadone, if it is going to be dispensed, it has to be dispensed by a federally licensed methadone clinic. The drugs are given such that when the patient walks out of the clinic, all the methadone is in their veins. They don't have any methadone they can use for diversion or something like that. Oxycodone is a semi-synthetic opioid. In the United States, it's only available in an oral formulation. It gets combined with acetaminophen for pain. There is a long-acting formulation that's used pretty commonly for chronic pain. It also comes in a couple of forms that are tamper resistant. People used to take oxycodone and grind it up and snort it. The tamper-resistant form, if you try to grind it up, it ruins it. It forms essentially a gummy mass that you can't really snort. So oxycodone comes both in a generic and in brand name versions. So when talking about the adverse effects of opiates, the biggest one to be worried about is respiratory depression. Tolerance to respiratory depression can develop with chronic use. However, if someone mixes opioids with other drugs that suppress the respiration, they can greatly augment the respiratory depression caused by opiates. So if the respiratory rate decreases to below 12 breaths per minute, you stop the opioid and you call the provider. The other side effect that is pretty common, this particular one is one to which you do not develop tolerance, and that is constipation. There are opioid receptors in the GI tract. Those opioid receptors in the GI tract, if they are activated, they will decrease, excuse me, decrease GI motility. So people who are on regular doses of opiates for pain will need to increase fiber and fluid intake and use laxatives like sodium docosate or bisacodyl or psyllium or benefiber or something like that. There are, however, some medications that are antagonists of opiate receptors in the GI tract. These drugs do not cross the blood-brain barrier. And they are used exactly for that. So these drugs are methyl naltrexone, this drug is available as a generic, but if there's a trade name, it's also called Relistor. Then there's another drug called naloxegol. This goes by the trade name of Movantik. The third one is naldemidine. That one's called Simproic. These tend to be used for cancer patients who are on opioids for chronic cancer pain. Because they're on relatively respectable doses of opioids, they will tend to suffer from constipation. These medications can mitigate that constipation. They do not cross the blood-brain barrier. So they, the blood-brain barrier, and consequently, they don't cause any euphoria or anything like that. So these will mitigate constipation. Induced. The thing to watch out when it comes to these drugs is that they can work a little too well sometimes. And so you might get some diarrhea. And with diarrhea, you're going to be losing bicarbonate. So you may have trouble with metabolic acidosis and electrolyte imbalances. So make sure you check electrolytes. And also make sure you check blood pH and adjust it accordingly. And the diarrhea is usually mitigated by reducing the dose. So dose reduction. And usually you don't have to check with the provider for that. That's something usually you can do. Because the provider will usually tell you they need this at either this or this or this dose. Oh, great. Power went out. Power's back on. Okay. Fantastic.
I don't know, my lights aren't, but other stuff is. It's kind of weird.
Okay.
I think it went to the generators now.
Oh, you're on generators. Okay. My wife told me that she is hearing trees creaking like mad and branches are breaking and there's just a lot of ice on them. So, all right. Oh, good gravy. Here we go again. So those drugs that are peripherally acting mu opioid receptor antagonists, mu acting, peripherally acting mu opioid receptor antagonists, and they're sometimes called PAMORAs, which is a nice way to say peripherally acting mu opioid receptor antagonists. Now, the other side effect of opioids that you don't ever get used to is meiosis. That is, you get pinpoint pupils. In fact, pinpoint pupils can be an indication that someone is abusing opioids. So orthostatic hypotension is another potential side effect of opioids. Tell the patient to lie down or sit down if they're lightheaded. Tell them to avoid changing body position quickly. You'll hear this in other classes, but dangle legs first. Plant your feet and put your weight on it, making sure you're hanging on to something. Assume straight body posture, upright body posture slowly. And then walk while hanging on to something. And then when it's clear, you're all right, then let go. So provide ambulatory assistance if necessary. Urinary retention is also a side effect of opioids. If you combine opioids with anticholinergics, like first-generation antihistamines or tricyclic antidepressants, that can make the urinary retention a whole lot worse. And so you want to monitor urine output. And that is one of your jobs as a nurse, is to monitor urine output. If urine voiding becomes an issue, you need to make sure they void every 4 hours. And if they can't, then you might have to put in a Foley catheter. Nausea and vomiting might be an issue with some people. So drugs you can use to mitigate that. There are dopamine antagonists like prochlorperazine, or anticholinergics like scopolamine. Or you can use serotonin antagonists, particularly those that antagonize the serotonin 3 receptor that is found in the GI tract. That's drugs like ondansetron and granisetron and other drugs like that. They all end in cetron. And then certain antihistamines like promethazine might also be a possible drug to use. to prevent that nausea and vomiting. Orally administered opioids will tend to cause more nausea and vomiting than parenteral or dermally administered opioids. And because they tend to act as cough suppressants, some patients, they're not able to clear secretions in their mouths very well. So you want to be listening to the lungs to make sure you don't have fluid accumulating in the lungs. So auscultate the lungs for crackles. Instruct the patient to increase fluid intake to make sure those secretions are nice and liquefied. Complications, of course, include sedation. So you must advise the patient to avoid hazardous activities like driving or operating heavy machinery. And then biliary colic, where you get spasm of the biliary tree. So you have a gallstone temporary blocking the cystic duct, and you get this sudden pain in the biliary tree. So you want to give, well, not give morphine to patients with a history of biliary colic. The best alternative in that case is the drug meperidine. If someone overdoses, your friend is Narcan. And you can see Narcan here. Narcan comes as a nasal spray. I have a Narcan tester. It's not a real Narcan, but you'll be able to see it here. So this is the Narcan test kit. Narcan nasal spray comes in a container that you strip open like this. There are 2 of these sprays in there. Do not prime it. That's your dose. You insert it into the nostril and you just dispense it. With the types of fentanyl and other types of drugs that are taking over the market, there's now a version of this that's not 4 mgs, it's 8 mgs. It's called Clodoxo. Clodoxo, Klodoxxo, Clodoxo. But you put it in, squirt it. The patient should come to right away. If they don't, take the other dose and administer that in the other nostril and give it a push. All firefighters and police carry this. EMT should carry this too. And frankly, I think this should be available over the counter in stores, but nobody cares what I think. So that's Narcan. And when you take your community health, the use of Narcan will be something that, and this is naloxone. Narcan is the name of the nasally administered form of naloxone. Naloxone works quickly, but it doesn't last very long. Naltrexone Naltrexone, like naloxone, is a opiate receptor antagonist. Whereas naloxone works very quickly, this particular drug takes longer to work, so it has a slower onset, but it lasts longer. Slower onset, but it lasts longer. If you administer naloxone or naltrexone to someone, they're not out of the woods. You still have to call an ambulance. They still have to go to the hospital. Because the naloxone is going to wear off and then they're going to be passed out again, not breathing. So there's another drug that was returned to the market called nalmefene. This drug is useful, but it can cause withdrawals, severe withdrawals. So use with caution. Just because it's so powerful. So the overdose triad is respiratory depression. The patient may not be breathing at all, coma, and pinpoint pupils, monitor vitals, intubate if you need to, and then administer naloxone, and naloxone usually will cause them to come to. But again, naloxone doesn't last very long. Contraindication for opioids include after biliary surgery because of the tendency to cause biliary colic. Meperidine is contraindicated in those who have kidney failure. The reason being is that meperidine is metabolized into a metabolite called normeperidine. Normeperidine can build up in patients with kidneys that don't work very well, and it can cross the blood-brain barrier if it builds up, and it can cause seizures, tremor, irritability, dysphoria, and it's particularly a problem in elderly patients who have impaired renal function. Opioids are also contraindicated in patients after delivery. You want to use opioids cautiously in pregnant women because the opioid can be taken up by the fetus. If given to ladies in labor, it will decrease uterine contractions. It will sedate the neonate. You can give the baby Narcan when the baby comes out. So my youngest, Emily, Carolyn was convinced she really wanted to do the last one with no anesthetics. And they induced her and they bumped her up. And she looked at me, she said, I don't think I'm going to make it. So they came in and they gave her some meperidine, and Emily came out kind of drunk, and they gave her some Narcan and she was fine. Within a few minutes, she was sucking on her fingers and doing things that babies do. Asthmatics can have their asthma exacerbated by the opioids. Because many opioids are lipid soluble in extremely obese patients, they can hide, well, let me be more exact, accumulate in fat tissue. There's a risk of apnea then in obese patients, particularly during sleep. If used in guys with benign prostatic hyperplasia, they can cause urinary retention. In patients with inflammatory bowel disease, they can cause paralytic ileus. The same can be said for people who are diabetics. Paralytic ileus is a problem in diabetes. Opioids can increase the risk of that. And of course, in those with renal or hepatic disease, you must dose the drugs down in cases like that. Those are the opioids. Does anyone have any questions about any of the opioids? You will see opioids on the NCLEX. That's just plain old, you will see them. You get questions about opioids all the time. All right. And without further ado, let's take a look at non-narcotic analgesics. In particular, let's look at the NSAIDs, the non-steroidal anti-inflammatory drugs. So the non-steroidal anti-inflammatory drugs include the salicylates. The salicylates includes aspirin, which is acetyl salicylate, salicylate, which is a dimer of salicate, and diflucinol. Diflucinol is also a salicylate. And then the other NSAIDs, the nonspecific NSAIDs, and a subgroup within the nonspecific NSAIDs would be the so-called classic NSAIDs. And then the specific COX-2 inhibitors. And then acetaminophen, which is really an animal unto itself, shall we say. So how do NSAIDs work? When you damage tissue, so we've got some sort of tissue damage here. This damaged tissue releases the bits and pieces inside cells. Those bits and pieces inside the cells will tend to induce a momentary vasoconstriction. That's to prevent blood loss. But several of the enzymes that are released by injured tissue will cause basophils and mast cells to release histamines. They will also activate the enzyme kallikrein. Kallikrein will take the kinin precursors and make kinins. And membrane lipids are subjected to chemical conversions into these lipid-soluble signaling molecules called prostaglandins. So these molecules will tend to dilate arterioles. They will tend to cause the endothelial cells of capillaries to not stick to each other nearly as tightly, so capillaries will get leaky. Kinins will bind to pain receptors and induce pain. Histamine decreases the pain threshold in pain receptors. And prostaglandins also will mediate pain as well. Prostaglandins in particular will signal to the hypothalamus to increase the body temperature, and that causes fever. And this explains the 4 signs of inflammation: redness, swelling, pain, and heat. Redness due to congestion, due to vasodilation of arterioles. Swelling due to fluid accumulation because of increased leakiness of capillaries. Pain due to stretching of tissue because of fluid accumulation, and also due to these other molecules that bind the pain receptors and other molecules that sensitize them to further pain. And then heat. Heat is due locally due to increased blood flow, and also systemically because you're signaling to the hypothalamus. I'll just leave it there, hypothalamus. Now, the conversion of membrane lipids to prostaglandins requires a couple of molecules. And to illustrate this, let's go to our makeshift blackboard to illustrate how this happens. So membrane lipids they contain a glycerol base. Glycerol contains these 3 hydroxyl groups. That's glycerol. And then attached to the glycerol, you have fatty acids. And then over here, you have a phosphate. And then you have something else attached to it that's just affectionately known as a head group. And that head group varies from lipid to lipid. It could be choline, it could be the amino acid serine, it could be ethanolamine, it could be the sugar, inositol, whatever. So that's your phospholipid. So hydrolysis of this ester bond here is carried out by phospholipase A1. And that liberates these fatty acids, free fatty acids. So this is activated by tissue damage. Now, one of the fatty acids that you find on these membrane lipids is a fatty acid called arachidonic acid. This is a C20 fatty acid, and arachidonic acid is a substrate for the enzyme cyclooxygenase. Cyclooxygenase is mercifully abbreviated COX. Cyclooxygenase will convert arachidonic acid into prostaglandin H, and then prostaglandin H is the starting material for all the other prostaglandins. But if you don't make this prostaglandin, you don't make these other prostaglandins. And these other prostaglandins, they mediate inflammation. Now, NSAIDs work by inhibiting cyclooxygenase. In doing so, NSAIDs will quell inflammation, they will quell pain, they will quell fever, and they will quell swelling. and redness too, for that matter. So that's how the NSAIDs work. Now, here's the caveat to this mechanism. When cells are damaged, there is a cyclooxygenase that is induced, and it's called cyclooxygenase 2. And this is induced. There's another one called cyclooxygenase 1. This is not induced. It is a housekeeping enzyme. And NSAIDs will tend to inhibit both of these. And that's how you get the side effects of NSAIDs, is that you are inhibiting this enzyme that you need. And the main tissues that will feel the brunt of NSAIDs are the gastrointestinal tract, in particular the stomach, the kidneys, and the blood vessels and heart. Those are the three places where NSAIDs will make their side effects most known. All right, Monday, we'll pick this up. We'll talk about the side effects of NSAIDs with regard to these three tissues. And then we will look, after we finish NSAIDs, we'll look at some of the other non-opioid pain relievers. Then after that, we will get into paralytics and we'll do something else. I just don't remember what it is, but we're getting close to being done with the neurological, muscle relaxants. Muscle relaxants, that's what we'll look at next. All right, so that's all for tonight. If you want, I will hang out here for a little bit, and if anyone has any questions, they can stay and ask questions. Other than that, I will see you guys next week, Monday. Blessed good night to all of you.
Drive safe going home.
Indeed, drive safely going home. Well, actually, I walk, so
Okay, well, walk safe because it's
I
bad
will.
there.
I'll try very hard, Devin. Thank you.
Bye, thank you.
Goodbye. You're very welcome.